every day. Hospitals, EMS services, and lay people across the globe use Zoll products to save lives.
Right, so what I'm going to do is I'm going to, as many of you know by now, the International Liaison Committee on Resuscitation, their role ends up being to review the science of resuscitation. And then basically the output of that process is a document that's called the Consensus on Science and Treatment Recommendations. And that document ends up forming the basis for then the councils, resuscitation councils from around the world to then generate their own resuscitation guidelines. So what I'm going to do is I'm going to share with you what the work of the Paediatric Task Force was, of ILCOR, and some of the highlights of the science review that we ended up publishing. 18 minutes now. What I'm going to do is I'm going to give you a brief overview of what the evidence review process was that ILCOR followed. And it's the same process that we followed for pediatrics as well as for the other task forces. And then I'm going to touch on some of the major changes that the science review process identified. And some of it was within pre-cardiac arrest for pediatric cardiac arrest. Some of it dealt with the intracardiac arrest phase, and some of it is post-cardiac arrest care. I'm going to go into this just, I want to acknowledge that there was a huge amount of work that was done as part of this process, and I'm just very much the spokesperson, shall we say, for all of these people that were the Pediatric Task Force that represented the councils from around the world, science experts from around the world. And I just wanted to note that there was a significant presence of members from the Resuscitation Council of Asia, and in particular from Singapore as well. And it wasn't just when it came to the task force that actually generated the CoSTR document, but even the evidence reviewers that actually created the foundation systematic reviews, a significant presence of Singaporeans as part of that process. So once again, just want to acknowledge them for all of their work that they did. So ILCOR represents all of these resuscitation councils. And up until now, it's been kind of a process where we review the science every 5 years. And then out of that, this document, the CoSTR document, and then the guidelines from the councils comes out every 5 years. That's going to be changing a little bit. We're not going to get into that in terms of what the change process is. But I will say that it's representatives from around the world that are part of this process. And the way that we ended up doing this is when we started off the cycle in 2010, these pediatrics resuscitation scientists from around the world ended up saying, what are the questions that we really want to answer? What are the questions that we think there's science out there that when it comes to people that are actually going to be following resuscitation guidelines, that we would want to make sure that there was a scientific foundation to help support guidelines changes. So we ended up using the PICO format. We ended up creating 21 PICOs. There were 21 questions that we felt that were important. And using the grade process, which I'll touch on very briefly, we ended up evaluating the evidence. And then out of that evaluation process, we ended up generating a consensus on science statement and a treatment recommendation where we could. And these were debated and ultimately signed off by the Pediatric Task Force. That floats up to the executive committee or the editorial board within ILCOR, and then it moved forward for peer review and then ultimately for publication within circulation and resuscitation. So I'm going to just be limiting my discussion to stopping here, which is the consensus on science. Many of you are aware of what your own guidelines are and how the guidelines themselves take the science that the science review generates and then contextualizes it. That's why your guidelines may be different than the UK guidelines, may be different than the Canadian guidelines. But as I said, we're going to stop here when it comes to talking about what the output is. So the thing that was new for us this cycle was we ended up using grade. And just as a sense, has anyone, just by a show of hands, grade, does this ring a bell with anyone here? Does anyone know about grade? All right, that's okay. That's how I felt 4 years ago. We didn't know about this either. And basically, it's a way of looking at the literature. And as opposed to just analyzing individual papers and grading them based upon the quality of evidence, it all ends up being based on looking at outcomes. So, for instance, if we end up looking at neurologically intact survival for pediatric cardiac arrest, for out-of-hospital arrest, we would be looking at not just the quality of individual papers, but analyzing all the literature for a specific PICO question with a specific outcome across all of those papers. So not an individual paper evaluation or assessment. It is actually evaluating the outcome and attaching a quality of evidence to an outcome and all of the literature that informs that outcome. So ultimately, the quality of evidence that we ended up, the quality of evidence label that we attach ends up reflecting how confident we are that the evidence is actually accurate. And I think it's important to recognize that as part of grade, randomized controlled trials are the gold standard. That's, basically RCTs start high, observational data, or observational studies start low. Those of us that are in pediatrics, our biggest challenge ends up being the vast majority of the data that we're starting with, the studies we're starting with, are observational. So when it comes to how the quality is assigned to this literature, one of our challenges ends up being that it tends to be low quality literature to begin with. There are ways that we can end up raising the quality of the evidence, but as I said, our bigger challenge ends up being we're starting low because it's observational data, and then often there are other things that drop the quality of the literature even more, right? And basically what ends up happening is that if we're having to use adult literature and extrapolate it to children, or if we've got small studies that we're trying to extrapolate conclusions from, those all end up leading to a reduction in the quality label that we attach to the study. So that leads to why even the wording that you see in the CoSTR document is different, right? It's all about recommend or suggesting in favor of or against. And that's code for basically if it's a strong recommendation, we say recommend. If it's a weak recommendation, we say suggest. And generally what we tried to do is we tried to say we're only going to use a strong recommendation if we've got good high quality data. We broke those rules a few times, and I'll show you in a few minutes what circumstances they were in. But for the most part, these are the code words, recommend and suggest, which are reflecting strong and weak recommendations. Now, out of the 21 questions that we ended up doing, our problem ends up being is that when it comes to the amount and the quality of the literature to support the questions that we ended up wanting to study, this was, in a huge percentage of the patients, what we were left with having to say as the ultimate statement. The confidence in the effect estimates is so low that the panel decided a recommendation was too speculative. It's such low quality data and there's so little data that we're not going to be able to make a recommendation. Now, councils often then did make a recommendation, but we are a science review process, and although it was painful at times, we ended up saying if we don't have the science, we're not going to stick our neck out and make a recommendation. What I would recommend to those of you that are interested in reading this document, the Consensus on Science and Treatment Recommendation document, October of either Circulation or Resuscitation is what this document was published in. And the reason I point that out to you is that attached to each evaluation, each question that we studied, at the bottom of it, there's a section which is called Values, Preferences, and Task Force Insights, as well as knowledge gaps. And as opposed to just a single line that says, this is what our consensus on science was, or the recommendation, this is actually, I think, very powerful and meaningful in that it really helps inform you as to the deliberations that we went through and where we struggled and where we ended up saying, here are some huge knowledge gaps that make it difficult for us to be able to make a final recommendation from ILCOR. So I'd leave you with that to take a look at when you have a chance in October of 2015, Circulation or Resuscitation. Now, what I'm going to do is I'm going to give you a brief overview. How many minutes do I have? About 7 minutes? 10 minutes? Great. I'm going to go through a few of the reviews that we ended up doing, and then in the interest of time, I'm going to be happy to speak with any of you about them. But I'll try and give you a background as to what led to us making some of the statements that we did. So first one, which is one of the most contentious topics that we addressed, was fluid resuscitation for septic shock. Now, I think it wasn't an aha moment, but where we struggled right from the beginning is the quality of the data that informs us right now to do the things that we do right now is pretty lousy data, right? Now, many of you end up knowing 20 cc's per kilo boluses of fluid as part of septic shock. That's ground into us, whether we're learning apples or pals in our various parts of the world. Where does that come from? Well, it's from papers like this, Joe Carcillo's paper in 1991, which is based upon 34 patients, suggesting 20 per kilo bolus is the way to go. Hans' paper out of Pittsburgh as well in 2003, showing that we should be aggressively using fluid, although that wasn't exactly the question that he was asking. But once again, the issue there, 91 patients. These are small studies. And unfortunately, that's why even though we ended up making some generic recommendations about what to do in terms of fluid boluses with septic shock, we did, and we said, yes, it's okay in many circumstances to bolus with fluid, severe sepsis, severe malaria, and dengue. We ended up having to say it was low quality data most of the time, and as a result of that, it was a weak recommendation. Now, what council said may have been different, but the science review process, we tried to be transparent. I know that Richard Aiken's going to go through the FEAST trial later on this morning, and I'll just leave this with you. This is what rocked us halfway through our review process, and this was out of East Africa. The children, very, very sick children, presenting with an entity called severe febrile illness. Some of them were in septic shock. And probably the biggest randomized controlled trial that's ever been run, I would think, probably in pediatric resuscitation, over 3,000 children. And really what it came down to, as I said, Richard will go into details, but it suggested that bolus therapy actually led to mortality in those patient populations. So we struggled with that. How do we end up balancing this with the low quality data that's driven what we have been doing for septic shock resuscitation for the last 20 years? It's not just that single study, though. There are signals that come out of other data. There's a study out of India that I think Richard is probably going to get to as well, which is actually, these are patients, as opposed to the FEAST trial, where those were patients, there was no critical care support. If you needed ventilation or inotropes, you were dead. This, in India, they did have the ability to do that. And these were sick patients, and it really compared a restrictive fluid strategy to a traditional non-restrictive fluid strategy. Restrictive meant early introduction of inotropes as well. And what they found is that they had pretty good mortality rates for the patients that they were dealing with, but the price they ended up paying was that there were a lot of patients that got a lot of fluid that developed hepatomegaly, and a lot of patients in both groups that were intubated and ventilated. You can have low mortality rates as long as you're willing to pay the price of ventilating and supporting patients in heart failure with inotropes. At least that's my takeaway message from this study. Same kind of message out of Europe. This was a kind of a single point assessment of pediatric septic shock in Europe that Patrick van der Voort published. And really what it showed, low mortality for children presenting in septic shock, but once again, a quarter of the children ended up ventilated, and almost half of the children ended up on inotropes. So we have to be careful how we interpret the FEAST trial when it comes to how you end up managing children, for instance, in Singapore. But the reality is that there are signals here when it comes to fluid is important, but there may be a price that goes along with it. And I'll leave it with you. There are more and more ICU-based studies in children and in adults that actually reinforce this. As long as you're willing to support children for longer periods of time on a ventilator in an ICU, yes, that will allow you to actually have lower overall mortality for these kids, but there is a price that you are paying. So this is what led to our recommendation, which was we suggest, right, because we ended up having to say that extrapolating the FEAST data, there was a lot of extrapolation going on. It was a weak recommendation because of low quality evidence. It's for these children that had severe febrile illness, like the children in the FEAST trial in East Africa, you have to be very cautious. We suggested against the routine use of bolus fluid, but that may not be the same kind of fluid or the same kind of disease states that we see in Singapore and North America. And as well, what we need to make sure is that we end up repeatedly assessing, reassessing our patients during therapy. I'll leave you, there was a few comments made about chest compression only CPR. Children, do we do it, do we not do it? And I think when we ended up combining data from the Japanese registries, Kitamura study and GoTo studies, the reality is what came out of it is there was actually a mortality risk that went along with using chest compression only CPR for children in out-of-hospital cardiac arrest, at least in Japan. So really, it weighed in favor of using conventional CPR, not chest compression-only CPR, which is what informed this decision. We recommend, strong recommendation, that you use, that we end up using conventional CPR as opposed to chest compression-only CPR. A strong recommendation. It was low-quality evidence, but that was low because we had to bounce it down for some limitations. Lidocaine and amiodarone. This was. If you get tired of something about a recommendation, wait 20 years and the recommendation is going to change again. What it comes down to, lidocaine is back. And lidocaine is back because of an observational study, observational, not RCT, but what it ended up showing that for children with in-hospital cardiac arrest, that outcomes, ROSC, and survival at 24 hours were actually improved with the use of lidocaine when compared to placebo. Now you can end up saying, who was getting placebo? Well, there were some children that were not getting, any antidysrhythmic for shock refractory VF or pulsus VT. The interesting thing here is there was a difference, at least in these short-term outcomes with lidocaine. When we looked at amiodarone, actually there was no benefit in short-term or long-term outcomes. So you end up saying, well, what do we do with this? Lidocaine's okay. Yes, limitation ends up being its short-term outcomes that are driving that recommendation. Amiodarone, well, we didn't have the courage to remove it from the recommendation. It's still there, although it does make you wonder whether or not lining one up against the other. 3 minutes, thank you. So Ecmo, I know that that you guys have a vibrant Ecmo program here in Singapore and also in parts of Japan and Taiwan. There is improved outcomes that exist with the use of Ecmo during cardiac arrest for refractory cardiac arrest. And I will end up saying that we ended up looking at all the data, which is unfortunately it's weak data. It's all case series. There's nothing prospective in terms of controlled data, unfortunately. But we did end up saying that for children with cardiac diagnoses who arrest in the in-hospital setting, we suggest that it's an option, right? Unfortunately, when it comes to children without underlying heart disease, the confidence and effect estimates was so low. There just isn't enough data. But for children with heart disease, it's a reasonable thing that if we can't get them back with conventional CPR, and if you have Ecmo and a program to be able to support that level of care, it's a reasonable thing to use for those kind of patients. Ian, you're going to be talking about temperature-targeted management. I'm going to leave that for you. There are some other post-resuscitation care issues. Oxygen management, thou shalt not allow the saturations to be 100%. Okay, when we ended up looking at the data, post-ROSC oxygen levels, if you look at this as the higher the PO2 is, either in kids that are blue kids with congenital heart disease or non-congenital heart disease, mortality does go up as your saturations are up after resuscitation. But that's nothing compared to the rise in mortality that goes along with hypoxemia. So we ended up saying, as a result of the data that we had, that we suggest, it's weak data, but still, we suggest that patients measure the PaO2 after resuscitation and target a value specific to the patient condition. And that was a way of sitting on that picket fence. We pushed it back to the councils to say, you guys in the Resuscitation Council of Asia or AHA or ERC decide how you want to use that very low quality evidence to drive your recommendation. Ventilation, where do we put the CO2 after resuscitation? We ended up saying target a value appropriate to the specific patient condition. It's very conflicting data. I know this is another example of sitting on the fence a little bit, but what we ended up doing is we said we need more data. And I think Dr. McConaughey is going to talk about some of the gaps that we have in data. When it comes to hemodynamics, where do we push the blood pressure in these patients? What do we accept? I think we know that myocardial dysfunction is common in kids after cardiac arrest if we get them back, but it gets better if we support them for a couple of days. Problem is what the brain needs in terms of cardiac output and cerebral blood flow is it's variable based upon the kind of patient. So we're left with saying, well, we've got some data that came out of Philadelphia that suggests that hypotension is very bad, but do we end up knowing that there's a specific blood pressure for a specific child that is the way to go in terms of targeting a blood pressure? All we were able to say at the end of the recommendation was that based upon very low evidence, we do make a strong recommendation that you avoid hypotension. So greater than the 5th percentile, when it comes to blood pressure. I know that's been a fast and furious review of the CoSTR process. Be happy to answer questions after everyone else has had a chance to speak. Thank you.